Well, I think it's about time for us to get going. So, hello everyone, and a very warm welcome to our second National Health and Care Analytics Conference and our final event in the series of online e-labs using system dynamics in local authority public health practice. I'm Rachel Caswell. I'm an analyst in the strategy unit, and I've been involved with the planning of HACA 2024, which celebrates the outstanding work of health and care analysts, bringing them together with leaders to showcase how analysts support high quality decisions. Last year's HACA was a huge success, and this year is even better with almost 180 abstracts. We've designed an amazing program with inspiring speakers, interactive workshops, posters too, and this is all centered around our theme of exploring the what, how, and why of analytics. So before I hand over to our guest speakers, I'd just like to remind you to keep yourselves muted during the session. Please do introduce yourselves in the chat box. We like to know who's with us today, and use the chat box to ask questions for our presenters or any technical issues that you've had. The sessions are recorded, as I've mentioned, and please do tweet about today's session or LinkedIn, whatever you prefer. We want to see magenta everywhere. That is our aim today, during the session and afterwards. So I would like to introduce our speakers for today. We have Abraham George, who's consultant in public health, Kent County Council, Mark Chambers, Head of Health Intelligence, and Nerosha, who's public health specialist. Peter Lacey isn't here today, so we'll be covering for him, but we'll be providing his details for any questions you may have for his part of this presentation after today's session. So without further ado, I'd like to hand over to you, Abraham.
Thanks very much, Rachel. So good afternoon, everybody. So our discussion today is mainly around how we've been using simulation modeling, particularly systems dynamics in our public health department here in KCC, and some of our reflections. So it's not going to be entirely it's not going to be entirely sort of discussed or sort of presented by technical experts. It's actually going to be the discussion is going to actually involve some of our team who are just on that sort of learning curve around how to actually use systems dynamics in our department. I'm just going to share my screen. I just want to double check if everybody can see the screen. Rachel, can you see that?
Yes, that's fine.
Excellent. Right. Okay. So before I go into the actual detail, I'd like to sort of share a bit of context first. So I'm just trying to change the slide. Yeah. Okay. So I'm not sure how many of you have actually seen this. This is the this is a sort of conceptual diagram I saw. I sort of stumbled into a number of years ago, called the Gartner Analytic Continuum. So I think it's helpful to actually show this diagram, which is helpful in setting the context, which is about the emerging importance of advanced analytics, particularly on prescriptive analytics. I think, dare I say, that in public health practice, particularly, and what we use in public health intelligence is very much focused around surveillance of health inequalities using high-level anonymized data to generate specific health indicators. So it just gives us sort of trend over time, and it sort of gives us that insight of what's actually going on in the past in terms of whether health inequalities or say hospital activity is getting worse or getting better, things like that. So I think we would call that something like in the context in the sort of realm of descriptive analytics. And if we're really lucky, we might have been able to integrate the data at row level so that we can actually understand or do some specific regression analysis to look at what in terms of what's actually associated in terms of those trends, whether they're getting worse or getting better. And that's in the realm of diagnostic analytics. But actually, what I think is really becoming more and more important, particularly not just in the NHS, but even in local government, is the need to use data to actually undertake predictive and prescriptive analytics. And the question framing is absolutely important. So we've been for many years we've been asking questions around what's happened and why did it happen. But actually, I think the questions that are being asked of ourselves is around what's going to happen in the future, and if we were to actually implement new solutions or new interventions to actually improve population health, what is the impact going to be? And this is where the system dynamic kind of modeling starts to become really useful in that context. So just to sort of give a brief story of what we've done in Kent, we've had for a number of years, I think it's going back almost 10 years ago, that commissioners within the Kent system were actually quite critical of the way we were using our, how we were producing our JSNA, which was mainly just sort of doing surveillance of health inequalities, looking at historical trends. But commissioners were actually asking us, well, can you actually tell us what's going to happen in the future? And, and particularly around where we need to, how we can make decisions around investing in the right sort of interventions, particularly around prevention. So there was a keen desire and vision and desire to transform the Kent JSNA into a forward planning tool. And in that regard, I happened to stumble across or met by chance Peter Lacey from Whole Systems Partnership, who had been doing some of that management consultancy work around different health systems using a particular kind of modeling methodology called systems dynamics, and so he offered some training to our team, for which I also partook in it. And then once I went through that training, I realized actually there's a whole range, there's a whole arena of system modeling methodology that we haven't really learned in public health practice. And I started trying to encourage and compel some of our team to start doing that training, which we'll come into shortly. Uh, Cut a long story short, we've generated a number of models, rather not we, but rather Whole Systems Partnership, and they've done it in collaboration with us in public health. Public health work sort of, or rather the intelligence team have actually been providing some of the data, some of the assumptions to help in the model design and development. What happened and then in 2017, the Kent Health and Wellbeing Board heard about this and actually asked Public Health in collaboration with WSP to create a cohort model that will help us test the impact of multiple prevention initiatives. And that will help us to generate that local evidence base for our system for wider strategic work. And then following that, we've done a number of training exercises with not just with our team, but also with the NHS, just to gain familiarity and understanding of how to model. So as Rachel might have mentioned, that actually we have presented the Ken JSNA cohort model in a previous analytical huddle, which was about a month back, for which I think Rachel will put the link to the in the chat. We are not intending to rehearse or regurgitate the whole sort of presentation that we did a month back. I'll do a quick recap, but what I really wanted to do introduce my fellow team to in and share their reflections and their experience around how they've used modeling. So, but before I do that, I just want to give a quick recap on the JSNA cohort model. So, what is the JSNA cohort model? It's basically a system dynamics model or a stock and flow model to estimate changes in population segments across stratified by gender, age, and different long-term conditions. The complexity of the model takes into account not just the demographic changes in the population, but also underlying risk factors, including deprivation, and then and particularly just developing those kind of scenarios to see if those risk factors change. Like, for example, management of hypertension. If that changed, how will that have an impact in terms of the prevalence and incidence of cardiovascular disease, for example? So system dynamics, for everybody's information, is one of many modeling methodologies, but it's increasingly used in circumstances when the scope of issues are strategic or population and at cohort level. It's not used for tracking individuals within a system. It's about, and it's when you really need to use it when you're trying to exert control over the system, and it's through looking at rates of the onset of the effect of different risk factors in the population. It's also used when the timescales are relatively long. So we're looking at, say, prevalence and incidence and healthcare demand, say, in the next 5, 10, 20 years. And so, so it's really useful in terms of looking at an impact of a particular policy or a strategy. And so in that regard, we were thinking that system dynamics is actually the most preferred sort of modeling methodology for our system, for our work in the JSNA. Again, so just to explain how the system dynamic model works, we've got to imagine a sort of bathtub where you have basically the health state of the population, which which may change from, say, being mostly healthy to being at risk of a long-term condition to, for example, having a long-term condition. And so the stocks are actually the prevalence of the population or patients needing treatment or people at risk. The flow is the incidence, cure, or mortality rates or patients entering a treatment. And the dynamic events are actually various factors like, for example, deprivation that might change incidence or changes in treatment or a new treatment care pathway. And then there are system delays where basically the treatment time or the time for prevention actually can be staggered over a period of over a prolonged duration period. So the way the model that we've created in the JSNA for our Kent JSNA is actually, as I've said, it starts with the mostly healthy group in the Kent population, moving on to at risk of a long-term condition, moving to single long-term conditions, and then followed by multiple long-term conditions, and then very frail. So, and we've applied lots of assumptions and rates across all of those different stocks and flows to actually then really understand how mortality would change, how would prevalence and incidence change, and particularly around and also around frailty and other aspects as well. One of the peculiarities of the cohort model, particularly because of the fact that prevalence and incidence affects differently across different age groups, we've used something called an aging chain, particularly for the adult section of the model, so that we are able to actually then finally apply some of those assumptions for those different age bands. And then the risk factors, as you can see in the middle of the slide, which may vary from the levels of smoking, the levels of blood hypertension in the population, cholesterol, weight management, physical activity, and then some of the long-term conditions. They're all sort of applied at pace and scale to see how that would impact on the population. And so, and what Mark will show you is some of the sliders and buttons that we use to actually then model to test out different scenarios. So I'm going to hand it over to Mark, and he will give you a very rich experience and reflection from his perspective of how he's used the cohort model or how he's been involved in the cohort model development in the last year or so.
Thanks very much, Abraham, and good afternoon to everyone joining us today. I'm going to share slides, just bear with me a moment. So I'll start just with a brief introduction to me and the team that I manage. I've been working in the Kent County Council for the past 3 years. Before that, I worked in Medway Council for about it was the best part of 10 years in the public health intelligence. And so in total, I've got about 17 years public health intelligence experience. And the team I manage is a team of data analysts called the Kent Public Health Observatory. And we're primarily work to support the Kent Public Health team, but we also work across the integrated care system in Kent and Medway. So I think the big key message I want you to take away, if you like, from what I'm going to say today is that I think this stuff is awesome, but also complicated. And I don't think there's any shame at all in sort of starting with simple concepts and building up. And that's really the goal of my team in this regard. So we're still learning. We don't have this, we're not the finished article. We've been working really closely with our good partners, Whole Systems Partnership, and unfortunately Peter Lacey is unable to join us today, but it's really been a very productive, close working relationship with them, and it's sort of not your average sort of consultancy type relationship. It's really been a productive one, so I'm very grateful for that. So we've got short-term goals, which are to become knowledgeable about how the model is constructed, to ask sensible questions to try to improve it, to be able to run different scenarios in the model, and to be able to sort of help others understand what's possible and what's not. Our longer term goals are to be able to create system dynamic models ourselves and to be able to make further refinements to this JSNA population cohort model, which I'm going to talk about in more detail over the next few slides. So it's worth just mentioning the public health service transformation. So as I'm sure if we've got other colleagues from other sort of local authorities across the country, there is a large amount of money spent on commissioning public health services. In Kent, the total comes to sort of tens of millions of pounds. But as I'm sure other areas do too, we have a rather simple ambition, or a straightforward ambition, which is to improve population health, but also critically to reduce health inequalities. And that sounds simple when you say it just like that, but we have to ask ourselves, what is the best way of achieving this? And I think one of the things I've picked up from working through this process over the last few weeks and months is that having to define things within a model really makes you think carefully about the strength of the evidence base that you're working with and testing your various assumptions. So this is sort of hopefully frames the sort of the thinking for the next few slides. So what we've been doing in my team is aiming to use the JSNA cohort model to help our colleagues in the rest of public health to make some really important decisions about how and where funding should be allocated in the next round of our commissioning review. So Abraham's touched on this already, and this slide is a massive oversimplification of what is the cohort model, but I actually presented this to across the whole of our public health team only a couple of weeks ago, and I wanted to sort of start with the most sort of fundamental principles. So there is a lot more detail, and if anyone is interested in finding out more, you're very welcome to contact myself, or obviously you can speak to Abraham, also Peter Lacey. So we'd be very happy to talk in more detail. But yeah, as Abraham mentioned, we've sort of trying to the cohort model projects forecasts health outcomes over a 25-year period. But anyone who's done systems thinking before or who's familiar with it, what the cohort model is, in essence, is a way of thinking of the health of the population as a big system. And there are various drivers that are obviously relevant to that. So age is one of the biggest factors, but there's also risk factors as well, and trends in terms of wider societal trends or other types of influence. And what the cohort model enables us to do is to run different scenarios by altering the risk profile or the exposure to risk within the population and seeing how that plays out in terms of disease incidence and other factors too. So over the sort of model lifetime of 25 years, we can see the cumulative impact of those proposed changes and compare them and quantify them. And of course, we're doing all of this in a safe virtual environment without having to spend money on any pilot programs or having to wait a long time to be able to see the results. It hinges, of course, on the quality of the inputs that go in. And that's what I was saying before, really, about really challenging the various types of assumption that we might make when we make these decisions. So the model itself is built in a product called Stellar Architect, which is sold by IC Systems. If anyone is interested, I mean, obviously that is a paid for system, but if anyone is interested in just dabbling with system dynamic modeling, there is a free tool called Insight Maker. So if it's just a case of wanting to have a little go and see what's possible and do fairly simple models, I would recommend you check out Insight Maker. But the JSNA cohort model is very large, and it's built in Stellar Architect, just for information. One of the things I really like about the system dynamic modeling is that it enables us to compare multiple interventions and their impact on multiple outcomes. And this diagram is supposedly trying to sort of show that in a simplistic way, but you might have multiple interventions that are happening, and they will impact on outcomes in various different ways. And rather than just look at a one-to-one or a one-to-many, we can have a many-to-many relationship. And the sort of dotted line cube is meant to signify the totality of the SD model. So within that, we would have the population, the local population, would have risk factors, we'd have different sorts of interventions that are happening and people flowing from one state to another. But yeah, this idea of being able to see the impact by having one or more interventions happening in parallel is really, really powerful. So I'm just going to talk about a couple of the things that we've been focused on in particular in Kent over the last few months. And the first one is health checks. And we're going to spend most time on this example. So we wanted to look at different scenarios for health checks. So obviously it's a mandatory service and rather a statutory service. So the scenario of not having health checks wasn't one that we genuinely considered as an option, but we wanted it as a baseline. So we had three scenarios. The first one was imagine we have no health checks at all. The second scenario was we just have the sort of standard universal program. And the third one was, well, what if we were able to slightly increase the uptake among the most deprived 20% across our population? So the model is suggesting that the main conditions affected by health checks are CHD, COPD, diabetes and stroke. And over a 25-year period, the model suggests that having a health check program reduces disease incidence by just under 4%. And there is a marginal additional impact of our rather modest scenario of just gradually increasing uptake among the most deprived. It was a further 0.1% reduction. Now, these are all provisional results. So all this work that I'm describing today is very much still a work in progress. We are right in the middle of this. So these assumptions, these outcomes need to be sort of sense checked and stress tested. But it sort of is indicating that if we wanted to do make a really big impact on health inequalities, we probably need to go further, or we need to do other things alongside this slight change we're considering increasing the tariff slightly so that we can incentivize up more with certain cohorts. So this is what the model suggests, and we take it forward into the next round of discussions. So just if people are interested, this is a screenshot of what the Stellar Architect model looks like. This is just a bit, I know it's very small, and I'm not intending for you to be able to read all of this stuff, but it's just to sort of give you an impression of the kind of detail that's within there. We've got stocks, which are the squares, and we've got arrows, which are the flows, and the little circles are called converters. So stocks in this instance are really just people moving from one health state to another. The arrows are sort of show that flow from one stock to another, and the converters are essentially all of our public health evidence and assumptions that go into that. What we know, the converters control the rate of flow from one stock to another. And I've got the little footnote there to say that this is about 1/50th. What you're seeing on the screen now is about 1/50th of the total model. So it's a daunting prospect as a newbie. But what Whole Systems Partnership have helpfully done for us is create an interface. So this is a user-friendly front end, and this is the one for health check. So again, apologies if it's a little bit small on people's screens, but what we've got here is these little drop-down boxes and text boxes for numbers and different things. They allow us to input different scenarios, and they link through to the model behind the scenes and are able to generate different outputs for us. So all we have to do is really change some assumptions by talking to local subject matter experts, and then click run, and then we compare the outputs, and they appear in a little box on the right hand side. And the model is split by local authority and also by condition and over time. And so we can then look at those outputs. We've got disease incidence, we can look at life expectancy, healthy life expectancy, and prevalence too. And that gives us the data to make our comparisons. The assumptions that this part of the model was built on uses sources like Health Survey for England. So there'll be the smoking prevalence among the general population, or the prevalence of people being overweight or having high cholesterol. That comes from national data, Health Survey for England. In terms of uptake of health checks by age group, that comes from national NHS health check dashboards, which are all openly available. And then there's also the relative risk ratios too that come into play. So the best available evidence is put into the model and run, but it's always possible for us to update and improve. So as and when we get new and better evidence, we can feed that into the model and gradually improve it. So weight management, I'm just going to sort of this is sort of less well developed, but what we want to do is to have a holistic view of obesity and associated conditions. And we want to incorporate not only the sort of long-term trends of what we're seeing, but also the effect of having different services. And we might want to invest more in one service than another and see what that overall impact is. Smoking, this is an example where we're looking at the outputs compared for COPD prevalence. So it's relatively simple concept, I think. The idea would be we've got our standard stop smoking service, but we're looking at not replacement services, but extra services, perhaps focusing on different population groups, and asking ourselves those sort of what if questions. Well, what if we were able to boost the numbers going through services by an extra 3%? What impacts might that have? And this is just an example with COPD. We can see the sort of blue line, run 1, is just things just carry on as they are. And the red one, run 2, is, well, yeah, what if we were able to achieve that sort of extra 3% going through services? Now, whether or not that 3% is realistic or achievable, that's a sort of a separate question, but we can adapt and change that according to what we think is realistic. So it's just hopefully giving you a flavour of the sorts of uses that we've put the model to so far. My last slide is really just an opportunity to reflect on a few things, and I think some of these topics and issues might come up in questions at the end. One of the big things I'd like you to sort of, anyone out there who's considering sort of following in a similar vein to us, I would sort of urge you just to consider that this is, when you sort of embark on something like this, you're not really buying a finished product that's going to give you all the answers you need ready-made. You're buying into a process, a kind of approach that you're going to take as a team, and it's not just the team of analysts that would do this. It's very much a team effort across wider public health and other partners. So we need subject matter experts to be able to guide the development of the model. But as Abraham's alluded to, public health is held in high regard by our partners, and they look to us to provide some of these key insights. And this sort of approach gives us the ability to answer questions like what will happen in the future, and what if we were to change X, what impacts might that have down the road? And that's quite a powerful tool to have at our disposal. There is sort of something that I think is worth mentioning, that the model itself is designed to show the impact across the whole population. So any intervention, the effect of that is effectively the outputs show the change within the whole population. So you might have a really, really good, high quality service, which is small scale, which is perhaps life changing for the people that engage with it. But if it's relatively small numbers, it's not going to translate into a big population impact. So for that sort of thing, this wouldn't be used to try to evaluate the effectiveness of a program like that. You would need to use different, more traditional methods, I think. So there's something to bear in mind. But yeah, what I said before, really, about really making you think carefully about the strength of the evidence base and highlighting where there are gaps, because that can be used to guide further research activity. So I think I'm going to stop there and pass to Nirosha, but yeah, very happy to pick up questions with people. And if anyone out there is thinking or has already started work like this and would like to partner up with us, I'll be really keen to hear from you, because I think the more we can share our experiences, the stronger the final product will be. So thank you very much.
Thanks, Mark. Yeah, so like very happy to introduce Nirosha, one of our public health specialists. Nirosha and myself are slightly different from Mark. We come from a non-analyst background, but Nirosha has very taken the initiative to learn system modeling, particularly for her portfolio of work, which is lead for drugs and alcohol prevention work and mental health. So over to you, Nirosha.
Yes, thank you, Abraham. Can you all see my screen and can you all hear me? Yeah, thank you. So, good afternoon, everyone. Thank you, Abraham, for the introduction. I'm Nirosha Disanayaka. I'm working as a public health specialist in Kent Public Health Team, and my work portfolio includes to enhance the health and healthcare access of adults living with multiple disadvantages, including substance misuse, mental health, physical health issues, and so on. So this presentation is all about how I used the systems dynamic modeling to understand the service needs of inpatient detoxification in Kent. For the inpatient detoxification, for the rest of my presentation, I use the short form IPD. Slides are not moving.
If you click on the slide itself, Nirosha, and then press the arrow button, it should work.
Right. Thank you. So, little bit of what IPD services are. I think you all must have heard IPD services. Services are an important part of the substance misuse treatment journey, so which is meant to treat adults who are severely dependent on drugs and alcohol. Here the dependent adults get round-the-clock care, that's 24 hours care and support in inpatient units. So the service is basically run by a consultant psychiatrist, and the dependent adults usually receive a withdrawal care plan with a short course of prescribed medication just to help them safely stop using drugs and alcohol, and as well as that short course of medication helps to manage their withdrawal symptoms as well. So usually this service is commissioned by local authorities. So Kent Public Health also commissions this IPD services to the adults, dependent adults, through our community providers. The community providers are CGL and Forward Trust in Kent. However, the unmet need for the IPD services is higher in Kent. That means fewer patients are entering the IPD services compared to the national average. Our average is worse than the national average. And at the same time, the number of drug and alcohol related deaths are rising in Kent. That is in parallel to the national trend, but the numbers are going up. So based on those findings, I wanted to understand the complex issues around this low uptake of IPD services and need to develop an intervention to enhance the uptake of IPD services. So here I used systems thinking approaches, which I learned in my level 7 systems thinking apprenticeship I just completed recently. Okay, so a little bit of methodology to identify the strategies, as I explained earlier, to increase the number of dependent adults using these IPD services. I went through these 5 distinct but again interconnected phases of intervention model called systems thinking and modeling intervention. So as the first step of that, I wanted to identify the problem. So Kent primarily sends dependent adults to 2 IPD units, Bridge House and Dame Carol Black unit. Both units are 9-bed hospitals. Altogether, in both units, we have got 321 bed nights allocation per year. So, but however, the Kent is overusing this allocated bed nights. And at the same time, I did a need assessment recently on IPD services, and I learned that there are more adults in Kent who need IPD services, and like we are sending only 50 patients to the IPD units per year, but nearly there are 200 adults in need of IPD services. That means we have the demand like 4 times the current users. So because of this high demand and limited availability, dependent adults have to wait longer than they should, and they are not getting the service that they need also. So obviously the key intervention that I decided for sending more dependent adults to the IPD units is making more beds available. So to conceptualize the intervention that I have chosen, I tried to understand how patients move through this dynamic system. This is a dynamic system from when they first enter the IPD services to when at the point they are discharged. For that, I evaluated the waiting times, then fluctuating rates of referrals and patient flow, like in terms of admissions, discharges, and the annual bed day allocation for Kent from both the IPD units. So by using all these things, I built this conceptual loop diagram. So I think this slide is a little bit familiar. Abraham also shared this at this stage. So I had the opportunity to undergo this SD modeling training program, which Abraham and Mark described earlier, and which was organized by the Kent, I think, Education Unit. So using the skills gained in that training program, I developed the SD model with the help of my analyst colleague. So this helped me to figure out the optimal bed capacity required to fulfill the IPD needs of Kent. I think this is a little bit of a messy slide, and this is again a screenshot of the stock and flow model that we got. So to create this, we used, I'm not going to describe everything here. The key variables we used here to create this stock and flow model are the referral rates, the patient flow to IPD services, then waiting times, then bed capacity in terms of annual inpatient days, bed days. So by using all these things, and by looking at years worth real-time data to estimate bed needs while minimizing wait times, we identified the bottlenecks in the patient pathways. Then we quantified like how many patients were stuck at each bottleneck. So after creating this stock and flow model, we turned this conceptual model into a fully specified stock and flow model. And here, as described by Mark also, we used the same software, Stella Architect. So finally, what we did was this model here, the previous model helped us to generate 3 different output scenarios. Firstly, we created these 3 potential scenarios by changing the referral rates and bed capacity. The key things were referral rates and the bed capacity, and they show how to improve bed capacity and service delivery so that patients can move through detox smoothly, how patient can move through detox smoothly. And also these scenarios can help me to identify how many additional bed days Kent would need each year to make sure like every dependent adult who is in need of this IPD services can safely get a bed with minimal waiting time. If I describe it a little bit more, so in these 3 scenarios, in the baseline scenario, what I checked was how long people would have to wait to get into IPD services over 3 years using the current bed capacity. I kept the bed capacity at the current level and referral rate at 25%. Again, it is the current level of referral rate. In this scenario, the average waiting time for a bed is like 69 days in the first year, but then it jumped to 105 days in the second year, and then again climbs it even higher to 143 days in the third year. So if we stick with the current setup, there is a big gap between the beds available and the demand for us. So we checked the second scenario, so that is called the scenario 1. So there we wanted to see what the average waiting time would be over 3 years using the current IPD capacity, but we increased the referral rate up to 30%. That means which is a 5% increase from the baseline referral rates. So here the simulation forecast that after 3 years, the average waiting time shoots up to 209 days. That 5% increase in referrals actually caused the waiting list to increase by over 45% compared to the baseline. So we checked the scenario 2. So there, for the second scenario, we wanted to estimate what would happen to the waiting times over 3 years if we added 160 more bed days. So we added 160 more bed days and kept the referral rate at 30%. That means 5% increase of the current one. Here the average wait time actually drops to 17 days in the first year and stabilizes at 15 days in the next 2 years. So with more bed days, obviously, and even a higher referral rate, we can meet the needs of the population actually better. And we can keep the patients moving through the IPD services smoothly. So with those, with that SD modeling, actually, I would like to say these are the key reflections. Like I can demonstrate like 3 key points I inform the commissioners, the average waiting time to access Kent's IPD services will get longer if we stick with the current setup. So we have to move from the current setup. With the current inpatient bed capacity, this service will become more difficult to access and fewer patients will end up getting treated. So what will happen is the health inequalities will be widened, because if we stick to the current setup, fewer adults with multiple disadvantages have the chance to get a IPD services. But if we increase the bed capacity by adding 160 bed days per year, waiting times will be improved, and to receive IPD treatment will also improve significantly, so that we can meet the local needs more effectively. So this model actually helped me to inform my team the importance of increase in the commissioning more bed nights. So based on the recommendations, actually the Kent Public Health Substance Misuse team, we decided to stay in. We are part of 2 consortia, so we decided to stay in the 2 consortia for the next financial years as well. So at the same time, we are currently trying to identify the possibilities of expanding the IPD consortia. So then again, as the last step, of course, I use this model along with other interventions, like locating wraparound support workers to enhance the access of dependent adults, especially the adults who are with multiple disadvantages, to enter the IPD services. This is all about my presentation, and I hand over to Abraham.
Thank you so much, Nirosha. So I'm just going to share my last slide to sum up on things. So I think hopefully what Mark and Nirosha have described is a microcosm of some of the complex analytical work we're doing in our team. I have to underscore the point: modeling cannot be done by one person; it's a team effort. It's, as I said, it's very complex, but it's a very useful, sobering experience to test impact of interventions and run different scenarios. A lot of the narrative that we hear nationally, that prevention will solve all our problems, but actually, when you actually run the data and actually do the scenario testing, it's not as simple as most people think. So I think it's really helpful for different analytical teams to actually take the initiative to actually test their assumptions to see whether actually the investment in prevention in their local health systems actually will have the desired effect on their population health. Stakeholder engagement is obviously critical to ensure the right scenarios and outputs are generated. The use of linked data is becoming more and more essential. Mark and Nirosha have mentioned standalone data sets they've used in terms of how the population cohort model, as well as the separate inpatient bed model that Nirosha did, how they've used that to populate their models. But actually, we really need integrated data to really test and confirm some of the assumptions, which will help in the validation and sensitivity steps for model development. Our public health intelligence team is gradually taking ownership of the model updating and refresh. We expect that will take for a number of years, a couple of years to do that. So Mark and his team are working tirelessly in that regard. Our ambition is to undertake routine scenario testing and simulations on our own. Sorry, it's not one, it's on our own, with minimal external help. But it is a marathon, not a sprint. So we don't expect to finish everything in the next couple of days. It is going to take some time. But the fact that we started quite early in our local health system has been beneficial. The knowledge and awareness of that kind of modeling capability and capacity has significantly improved. So the rest of the NHS are actually are consulting with us around some of this modeling outputs and maybe doing further spin-off modeling initiatives. And finally, these are the publications that we've already published. One is about about an earlier community of practice that we did, funded by the Health Foundation, around how people's experience of doing modeling. And the last two publications are, one is about the JSNA cohort model, and one is about the actual system dynamic model we created around COVID, building on the JSNA cohort model. Both are all open access, so you can all of them are open access, so you can freely access them. I'll stop there and hopefully hand it back to Rachel.
Thank you all. Thank you very, very much. I really enjoyed hearing about your experiences of system dynamics in Kent, and I've been scribbling down some questions that some of them you've answered, but we've got a couple in the chat as well. So I will, and I know you've been rather brilliant, Abraham and Mark, about answering some of the questions in the chat as we've gone along. So you've made my job very easy. So thank you very much for that. You are invited back. So one of the questions was really great to see. Have you been doing it long enough to test closely how closely model and assumptions predict what happens? So I think you have been doing some tests, but would you like to answer that one, Abraham?
Sorry. So yeah, absolutely. We've been using the modeling for testing a lot of us. We've been applying assumptions and testing it on a regular basis for different aspects of the model. But I think Nirosha wanted to come in.
Yes,
on that point.
I think if I can answer that question, like we tested the model like this bed model by running it for several times. So we tested it. So that's how I think the bed model, in terms of bed modeling, that's how we tested it.
Okay, that's very helpful, because I think, Abraham, you probably covered it in some of the information you've shared, but you've been involved with this for some years now, haven't you? So you've been, and as we're saying, this type of approach, it isn't something that you buy and use. You evolve. It becomes part of you. We're talking Marvel again now, aren't we? I know that was before the session. Yeah, so that's something that you're very sort of familiar with and experienced with in that area. And like you say, it's growing, and others are adopting these types of approaches as well. There's another point here. How often would you review this in terms of what has happened due to suggested changes? So how often do you review, or would it depend?
Yeah, so this is the challenge. So we had an initial bit of money when we first started this work in 2017. We had a little bit of money that was invested by the council to set the whole model up, and then as a result of that, the NHS were very interested in that because they're part of our Health and Wellbeing Board setup membership, and so they commissioned WSP to do a number of spin-off models in that regard, particularly around frailty. And then COVID struck, and then the whole direction of travel around model development changed when we were specifically developing model outputs for COVID. Again, the NHS stepped in to fund that. There was because of the urgency around financing and delivering local COVID response. After the pandemic, post-COVID, that is, we've managed to secure some funding from our council to actually do the next update and refresh for the JSNA cohort model. The intention is that we will hope to retain WSP as a retainer to actually advise us around specific processes and procedures for model updating and refresh. And that's where Mark and his team comes in to just fine tune or curate the right sort of data sets to then use as assumptions to plug into the model. So the intention is that we would update this on a regular basis, possibly maybe every year or every couple of years. The model is not intended to be used real time for say operational kind of work. It's mainly for strategic planning purposes.
Okay, that's very helpful. Stacey's put a question around the intellectual property of the model. Does the intellectual property of the model allow it to be converted to open source, e.g. through the ASDM Python library?
Right, you put us in a very difficult, this is a very technical
That's what I'm here
question.
for.
So I
like
think
a
I would,
challenge.
yeah, I think I would, I probably, this is something that needs to be answered
Mark's
offline
got
with,
his hand up. Mark's got his hand
oh,
up, but
sorry, Mark, maybe Mark is there to
you don't
rescue.
have to answer the question if it's easy to answer it later.
I think Abraham was going to say what I was going to say is I think it's a question to be directed to Peter. So we could, I think you've put his contact details in the chat. So I think it would be good to speak to him. It's not open source. So I think the answer is no.
Okay. We've got time for just this one last question, which is we have done some work with modelling in oral health, not as complex as the models that you've been presenting. One issue they faced is the best available data. Hopefully the oral health field will catch up on these great tools and similar to systemic health. So obviously data, the quality of data that you have available is incredibly important to you.
Yeah, so this is where the answer to one of the earlier questions, which is you need to do a bit of validation. There's a validation step around model validation to determine model versus actual trends. So the best available data that you have will be used as to initialize the model, say a year or several years before year zero. And that will be then, and then you undertake a validation step to see whether there's the distance to target or the variance is reasonable enough to actually then allow the model to do scenario generation, if that makes sense.
Okay, it does actually make sense. Thank you very much. And with that, we just have about 1 minute to go. And again, I've done a rather marvelous job of chairing, so well done me. But also thank you so much to Mark, Abraham and Nirosha, and Peter in his absence who put a lot of effort into the preparation for the presentation today. I've really enjoyed the session that you put together for us, and all aspects of system dynamics. And I agree with Mark entirely. It's awesome. It really is. It's I think when you've been in it for some time, and I've only sort of touched the surface of it, but when you see the capability and you see the potential for this in so many different ways, I think it's really something that we should be spreading the word with in a big way. And I was particularly interested to see how you engage with stakeholders early in the process. And I've got so many questions about your top tips and all sorts of things for others who are interested. But I was particularly interested in how you engaged with stakeholders early. It's really early in the process, so important. And how you manage to influence senior leadership decision making, which of course is involving commissioning and so on. Now that is particularly important because it's such a strong theme in this year's HACA. And on that, I would just like to thank you all for coming today, and I would love to see you in Telford in a few weeks' time. If you're not able to make it in person, then we do have the availability of online access to all of the sessions bar the workshops. I'm going to be doing a workshop with Professor Mohammed, about the analytical concepts for leaders. There goes my cup. It must be lunchtime, and lovely to see you all. Thanks for coming, and hopefully we'll see you again soon. Thank you, everybody. Bye bye.
Thank you.
Thank you.